Welcome. I'm Dr. Leonard Calabrese from the R.J. Fasenmyer Center for Clinical Immunology. And today I'm going to be talking to you about ideal management, comorbidities, avoiding infectious complications, and the disease at hand is psoriatic arthritis. I think that psoriatic arthritis is a case study in an autoimmune, autoinflammatory disease where comorbidities are common. And while it's a skin disease, it's a serious disease. Complicated by arthritis dramatically increases the morbidity. The good news is that we now have increasingly effective therapies, and the pipeline is quite rich to move us forward. So after kind of thinking about this illness, let's move and talk about our therapies. I'm going to break this into three parts. I'm going to talk about indications for aggressive therapy, then I'm going to talk about biologic agents and certain key comorbidities such as infections with TB, fungi, and viruses, and then we're going to talk about some best practices that might help us in dealing with our patients. So this is an overall chart of the treatment options for patients with psoriasis and psoriatic arthritis based upon the different distribution of disease. We can look at patients as having pure arthritis, pure skin disease, or other musculoskeletal inflammatory diseases such as enthesitis, dactylitis, and axial disease. And we have numerous modalities here that we can use. Now, the next slide, which are the GRAPPA guidelines, put that into action. And here we see patients with psoriatic arthritis with whatever complication of interest, starting with peripheral arthritis, skin disease, axial disease, dactylitis, and enthesitis. And here are starting therapies and how we then escalate based upon need. You don't have to be extremely knowledgeable in this area to see that the only drug that is found in each one of these boxes at the bottom are TNF inhibitors, biologic therapies. So one of the advances in the take-home management is that TNF inhibitors, biologic therapies, are used for all forms of inflammatory disease in psoriatic arthritis. And this is really kind of the linchpin of where we want to protect our patients from the attendant side effects. How we get there, I would tell you to go back to the original paper, Artie Cavanaugh and colleagues on the GRAPPA guidelines. So here's the current armamentarium, and close to the armamentarium that we will be seeing, we have multiple TNF inhibitors that are being used now to treat psoriasis and psoriatic arthritis, most of which are approved. There is one IL-23, IL-12 inhibitor that is approved for psoriasis, where we're getting growing data on its effectiveness in psoriatic arthritis. There are others in late-stage clinical development. An exciting area of new molecules which we are keeping our eye on are the anti-IL-17 agents. Ixekizumab has recently been reported to be highly effective in chronic plaque-like psoriasis. There are several other IL-17 directed agents such as brodalumab and secukinumab that are different permutations on targeting cytokine or receptor that we expect to see a lot more of. So this is a field rich in pipeline and small molecules are also in clinical trials. Each of these have different signature side effect profiles. So now let's look at some of the adverse events of interest. Serious bacterial infections, TB, fungi, and viruses. If we look at all biologic therapies and look at the major types of infections that we are seeing. And this is a study reported by my friend Kevin Winthrop. You can see that it is rather broad. And there are certain infections that are unusual, but increasingly reported, such as some of the endemic fungi, agents such as listeria, parasites. But the ones that seem to dominate are still mycobacterial infections, which I'll comment on in a minute, bacterial infections such as invasive pneumococcus and staph. So when we use advanced immunobiologics, we have to be poised to deal with these. This is kind of high altitude. Much of this is known to us, but two recently accented infections that we need to focus on a bit are Legionella and Listeriosis. Legionella is potentially fatal, often is associated with a pneumonic component, and it has been shown to be linked to TNF inhibitors. Listeriosis, a serious infection often caused by contaminated food, where vulnerable populations have long been known. We now add TNF inhibitors to this group, so be vigilant for these infections. Here, with cavitary disease, would be classic patient with a mycobacterial infection. Interestingly, we knew about this disease only since about 2001. This is the New England Journal paper by Keene et al., which shows the pattern of pathology in the lung of TB in infliximab-treated patients with RA. On the top, you can see the well-formed granuloma in the left-hand upper quadrant and the CD68-positive macrophages in the right upper quadrant. Down below is a patient with mycobacterial infection showing absence of granuloma and absence of CD8. The meaning of this? 1, the pathologic picture of TB can be different. 2, the basic underlying immunopathology is different, and that's why it is a formidable complication. So what are the risks? How can we define them? Well, here is a epidemiologic study by the British Biologic database looking at the TB risks in patients on DMARDs, all TNFs, and then broken down into individual agents, at least etanercept, infliximab, and adalimumab. 1, you can see that in non-biologic DMARDs, there were no cases in 7,000 of rheumatoids treated, where in the all TNF group, there were 27 cases for a rate of about 95 per 100,000. When we broke down the risks in terms of etanercept, infliximab, and adalimumab, there are palpable greater risks with the antibodies than the receptor construct. Does not mean that etanercept does not lead to TB, but quantitatively these were different. This graph really tells us several things. 1, it shows the incidence of TB after starting these 3 different biologics. And the important thing is that after starting infliximab and adalimumab, you have a kind of a rapid upsurge and then tapers off. With etanercept, there are cases that are reported, but they're equally distributed over time. What many people have interpreted this to represent is that etanercept probably does not contribute greatly to reactivation of latent TB. It compromises the ability of the host to contain new TB infections. So if you're in a high incidence area, whether by travel or living or other circumstances, it also poses a risk. So I think this is an interesting study. So what are our best practices? How do we deal with this? Well, this is one problem that by and large has been solved by risk mitigation. We screen for TB and assess for risk factors in all patients before biologics. How? We test them, either by skin tests, standard TST, or by one of the interferon gamma release assays. When we find a patient who has latent TB, we treat them for latent TB. And if we can hold off for a month, then we can start the biologic while they're still getting it. But most of all, we maintain vigilance for this. And I like to take these histories on a routine basis. Have you traveled to an endemic area? Have they been hospitalized or placed in a nursing home or an extended care facility in the meantime? I'll point out to you that we have an outstanding program on the Fasenmyer Cleveland Clinic website right now called Tuberculosis in the 21st Century. We have 5 world leaders on TB and autoimmune disease discussing state-of-the-art in testing, prevention, and the immunopathogenesis of biologics. So come back and visit us on the website. A quick note about the interferon gamma release assays. The CDC says that they are interchangeable with TST under all circumstances. And at the Cleveland Clinic Foundation, in our department, we no longer do tuberculous skin tests. All patients are screened with IGRA. They're more specific, the reproducibility and accuracy is better, and they're easier for us to track in the electronic medical record. And in our institution, they are more cost-effective. These are some of the data on IGRAs and the anti-TNF showing how well they work, and particularly for patients who have had previous BCG, it is unencumbered by false positives because of that. This next slide, this piegram, again by Kevin Winthrop, tells us 2 things. This is looking at using an ID network for rare diseases to track opportunistic infections on patients and biologics. And as I said, 2 things it tells us. 1, TB doesn't occur very much these days because we're so good at screening and watching out for it, and in the United States, we're a low-incidence area. But if you look at the big pieces of the pie, you can see that now the biggest piece is non-tuberculous mycobacterial infections. So these are mycobacteria that are epidemiologically distinct, and we must maintain vigilance for MAI, Chelonae, Marinum, and others, depending upon our patient population. I would finally want to just reemphasize is that routine rescreening with tuberculous skin tests or IGRA is really not indicated unless you're in an area of extremely high mycobacterial infection. In our institution, we rely on epidemiologic history, and if there's a change, then we'll consider retesting. So let's now move on and talk about some other agents. Invasive fungal infections are increasingly important in patients who are on biologic therapies. This is an older MMWR release based upon these data showing that TNF inhibitors are associated with a wide range of fungal infections, including histoplasmosis. Now, we are at the upper end of the histo belt. We don't see that much, but we reproducibly see patients with histoplasmosis every year. I'm personally convinced that most of these patients are newly acquired by living in an endemic area and are not reactivations of histo. Histo can be a great mimicker. It can look like sarcoidosis with lymphadenopathy. It can look like simple pneumonia, or it can be disseminated. And, of course, notoriously can cause mucositis. So we have to have a high index of suspicion. Multiple other fungal pathogens are also seen, and we need to keep an eye out for them as well. This next slide that we're working on shows another picture of another opportunistic infection. And what you see in this MRI are the white matter lesions of progressive multifocal leukoencephalopathy. This is a disease that's been known for over 50 years, originally reported in leukemia and lymphoma, and now increasingly seen in patients on immunosuppressives. Transplants in about 2% of patients have autoimmune and autoinflammatory diseases. It has been linked with a number of biologics. The strongest is with natalizumab, a drug which is very potent and effective in multiple sclerosis. While the overall risk of PML with natalizumab is about 1 in 1,000, certain subgroups of patients on prolonged therapy with background cytotoxic therapy may have a rate approaching 1 in 100. Rituximab has also been associated with PML and autoimmune disease, but in rheumatoids, we believe that that risk is somewhere between 1 in 20 and 30,000, so a very rare event. Eculizumab, a drug used to treat psoriasis, had a strong association. This was voluntarily removed from the market and is no longer with us. What about anti-TNF? Well, in the FDA database, there are no definitive cases, but there are a few peer-reviewed cases now reported of definitive PML. But recognize we have been using anti-TNF for over a decade, and over 3 million patients have probably been exposed to anti-TNF inhibitors. 2 cases among 3 million means it is an extraordinarily low risk. I would welcome you back to the R.J. Fasenmyer Center CME site and go back to our PML monograph and roundtable discussions if you're interested in hearing more about this. Our bottom line is that PML is a potential complication in all patients on immunosuppressive therapy, and we have to have vigilance. New onset, focal and non-focal neurologic signs in patients with new onset white matter lesions need to be thought about as PML. If you're uncomfortable, neurology, infectious disease consultations may be indicated. Let's return and talk about another morbidity in our immunosuppressed patients, and that's dermatomal zoster. Zoster is ubiquitous. We have all had chicken pox if we were born before 1995. After that, our population is immunized. If you live to be 85 years old, about 1 in 2 people will ultimately get the shingles, dermatomal zoster. In and of itself, it's a bad disease. It is painful. And unfortunately, a small percentage of patients associated with complications ranging from the most common, post-herpetic neuralgia, to motor involvement, central nervous system involvement, ocular involvement, and others. So this is something that we want to keep our eye on. We know that VZV infection is seen in patients on immunosuppressives. And this study by Galloway shows us the rate of shingles in patients on all anti-TNF inhibitors is increased compared to those on DMARD controls. We would expect the same to be seen in a psoriatic arthritis population, and thus we need strategies to how to recognize it, treat it, and to prevent it. So let's move in and talk a little bit about vaccinations. Ever since 2008, we've had increasing recommendations on our vaccine guidelines from various sources, ACR and CDC. And in fact, the 2012 updated the 2008 recommendations on biologic and non-biologic DMARDs in RA patients have recently been published and are more explicit than ever. It basically tells us several things. One, if we take care of patients with inflammatory arthritis and we're using immunosuppressives, we need to be involved in these decisions. That before we plot our therapy, whether it be biologic or non-biologic, we need to get our patients up to speed on their vaccinations. I believe that all patients who are on these types of immunosuppressives need to have pneumococcus regardless of their age because they fall into the category of immunocompromised patients. They will need to be reboosted within 5 years. Also, we need to know whether they need boosters for everything from Tdap, and have they had their yearly influenza vaccine. What about our use of live vaccines, such as Zostavax? Well, that is the one area where we really need to strategize. I think this is an outstanding vaccine. It is currently indicated for patients over the age of 60, though the FDA approves it down to the age of 50. If you're on a biologic DMARD, it is in the package insert written as a contraindication. Now, there are growing data from some epidemiologic studies that these risks may be more theoretic than real, but I think that in our practice we have to abide by those recommendations. So what is one strategy? Well, I think that before a patient goes on a biologic DMARD, even if they're down to the age of 50 or thereabouts, I seriously discuss giving them Zostavax, even if they have to pay for it out of their own pocket, although many of these patients can have it approved. If you give them Zostavax and wait merely 14 days, then they can start the biologic. If a patient is on a biologic, they should really stop for 28 days before getting this. If they're just on methotrexate and prednisone, they can get Zostavax. This is a highly effective vaccine, as I said, and we should move along from there. So let's now wind this up and try to reduce this to some best practices, and I'll break it down into three areas. Before we prescribe our drugs for psoriatic arthritis or inflammatory arthritis of any sort, at the time of our drug selection, and we give them a prescription, and then after they're on it. So what about beforehand? What do we do to help assess the weight of our comorbidities? Well, I like to get an immunization history. Are they up to date on their adult vaccines? And do they have any special type of risk factors for infection, such as foreign travel? What is their previous history of these type of unusual infections, such as TB, endemic fungi, and others? Do they vacation on Cape Cod? Are they subjected to parasitic or borreliosis type infections? Also, reviewing their general overall health and vaccine recommendations, as I said, can complete the medical record and keep this separately and retrievable. Now, the second stage of this is looking at patients at the time of drug selection and writing that prescription. And either you as the physician or you as the allied health personnel need to engage in increasingly complex, shared and informed decision-making regarding important and notable complications. Some patients may have particular fears. They had a patient with a relative with a neurologic disease, and they've heard of PML or MS. They've heard about infections, or they watch this on the commercials on TV and hear about lymphomas and malignancy. There are many materials by the companies and other sites that help explain this. I really think that this is an area where we need to test the health literacy of our patients. You know, a lot of this is using big words and complicated matrix of decision-making. I like to use the talk-back technique after I've explained the difference between TNF inhibitors or between TNF inhibitors and newer drugs in the pipeline. Tell me what I just told you. What is your understanding of the risks of these agents? And give the attendant drug information, which comes with every single biologic, whether it's in the box or the infusible. This is important risk mitigation and instructional data. Now, we've had our pre-meeting, we've had our meeting at the time of drug dispensation, and now the patients are on therapy. So what is the best practice for preventing infections while on these potent immunosuppressive drugs? And here where cooperation between physician, nurse practitioner, or PA, or RN is and the patient is so important. I want that patient to leave with a plan for fever, saying we're not expecting you to get sick, but in the event that you do get sick, here are some guidelines and caveats. I don't want you staying at home for 10 days with a high fever without letting someone know. So we tell what are unreasonable. Temperature of 102, I want to know. Sick for more than 2 or 3 days, I want to know. For those on infusibles, which we may not see and the doctor doesn't see every time, we need to kind of create a punch list of recent infections in between these things. Have you been on antibiotics? Have you been hospitalized? When you ask about antibiotics, really tell them what has been given to you, because their primary care doctor might have done that. And then we like to do a brief review of systems. Are there any new symptoms related to respiratory infections, ENT infections, any neurologic signs or symptoms, abdominal pain, etc., going on? And then we give the infusion. Sometimes it's the communications, the advanced communications with our patients, that spirit of shared and informed decision-making that makes the difference between just giving state-of-the-art medications and state-of-the-art care. So, in conclusion, I think you should deem all patients on immunosuppressives, especially those on biologics, to be immunocompromised, and our vigilance needs to be hyper. We need to have some familiarity if we're engaged with these drugs and the spectrum of opportunistic infections, particularly some of the major ones such as TB. And then we need to develop our surveillance practices and our preventive practices. I think we really need to get up to date on our vaccines. If you're not going to administer them in your office, work with their primary care provider on getting them up to date. And then lastly, please re-review what we consider to be the best practices of making medications for psoriatic arthritis as well as other autoimmune and autoinflammatory diseases as safe as they can be. I'm Dr. Leonard Calabrese. I want to thank you for participating in this program. Please come back and explore the R.J. Fasenmyer website. We have many, many programs on efficacy of biologics, safety of biologics, other comorbidities. We have case-based programs such as rheumatology virtual grand rounds, highlights of recent diseases and rheumatology highlights reports, and of course, May 2013, Biologics 5, live in Cleveland. Please be there.